Hello, I'm Dr. Robert Miller, a periodontist in Plantation, Florida. Today I'm presenting the education module on the choices that we have in guided tissue regeneration. This education access module is a collaboration between the American Academy of Periodontology and LifeNet Health. The content was developed and provided by LifeNet Health. This is LifeNet's disclaimer for this education module. What I'm going to do is I'm going to break this presentation up into a couple of small parts. The first thing we're going to do is we're going to discuss the demographics as it relates to periodontitis. Secondly, we're going to talk about the choices that we have in guided tissue regeneration. And then lastly, I'm going to use my own personal cases and show you my thought process as to whether or not I want to save the tooth with guided tissue regeneration or extract the tooth and possibly place a dental implant. Interestingly, if you review the periodontal literature, about 5 to 20% of the population suffers from a severe periodontitis. There are many risk factors such as smoking, diabetes, age, medications, and also stress will also increase its incidence. There's a lot of evidence that links periodontal disease with cardiovascular disease, diabetes, as well as pregnancy risks. Of those 5 to 20% of the population, only about 60% of those patients are actually treated. 90% of those 60% of patients are treated with scaling and root planing alone, with or without antibiotics. Only about 10% will actually be treated surgically or comprehensively with flap and osseous surgery, GTR, or biologics. Interestingly, though, periodontitis still is the main cause for tooth loss in adults. When we decide we want to use guided tissue regeneration, there's several questions that we have to ask ourselves, and one of them is the graft material. For many of us, autogenous bone remains the gold standard. Why? Because obviously it's osteoconductive in nature, it scaffolds nicely. It's also osteoinductive. There's growth factors associated with it, therefore having osteogenic potential. However, there are limitations and complications associated with it. Yes, there is pronounced resorption, particularly in particulate autogenous bone. Often a secondary surgical site is necessary to harvest this bone. And obviously there's morbidity associated with that. Oftentimes there's limited donor sources intraorally, so graft availability becomes an issue, and sometimes we have to go extraorally for larger defects. Therefore, the time, the cost, the morbidity associated with it often affects patients' acceptance rates. And they're often looking for a secondary option, a second option. So for many patients, allograft seems to be the treatment of choice in many situations. And this comes in both mineralized and demineralized freeze-dried bone. And there's also a fresh frozen bone. Allograft meaning the same species, human freeze-dried bone. A second option is xenograft, coming from a different species, such as bovine, equine, algae, as well as coral. Another option is synthetic bone grafting materials such as an alloplast like bone ceramic and calcium carbonate. These are basically your choices. So with that being said, we have to decide which bone to actually use for a particular defect. And with that, we have to ask ourselves other questions such as osteoconductivity. How well does it scaffold? What's its turnover rate, its rate of resorption? And also, is there any growth potential? Is it osteoinductive in nature? Is it osteogenic? So looking at osteoconductivity in terms of scaffolding, well, all four options seem to scaffold nicely: autogenous, allograft, xenograft, as well as synthetic bone grafting materials. Which bone turns over the quickest? Its rate of resorption. Typically, autogenous bone wins that race, with a demineralized freeze-dried bone also turning over rather quickly. Mineralized freeze-dried bone turns over a little bit more slowly, but xenograft as well as synthetic grafting materials seem to last the longest, stick around the longest. Now, which bone is actually osteoinductive? Which bone has osteogenic potential? Autogenous bone has the most osteogenic potential, having the most growth factors with it. However, demineralized freeze-dried bone, there's a lot of literature to suggest that this also has osteogenic potential. Mineralized freeze-dried bone, xenografts, as well as synthetic bone grafting materials do not have osteogenic potential. There's a very interesting article that was published back in 2015 by Drs. Borg and Mealy. What they did is they compared a mixture of demineralized and mineralized freeze-dried bone, and they compared it to mineralized freeze-dried bone in terms of dimensional ridge changes as well as new bone formation. What they found was that there's actually no significant difference between the two groups in terms of alveolar ridge dimensional changes. They used a mixture of 70-30, 70-30 min to dmin. And what they actually showed was when they compared this mixture of bone to mineralized freeze-dried bone, what they found is there's a lot of evidence showing greater new bone formation with the combination of min and dmin. And also, obviously, there's no alveolar ridge dimensional changes, making this maybe the better choice when using allograft. Now, where did guided tissue regeneration actually come from? You first started seeing this in the literature in the late 1970s, early 1980s. Investigators like Drs. Caring, Stuart Neiman, Jan Linde, and others often published on the concept of using barrier membrane technology to affect bone growth around natural teeth. A little bit later on, the late 1980s, early 1990s, guided bone regeneration started appearing in the literature. And this was the use of barrier membrane technology to affect bone growth for the purpose of placing dental implants. Now, why are we using a barrier membrane? The barrier membrane acts as both a biological and mechanical barrier, which prevents the invasion of cells, particularly epithelial cells, which are not involved in new bone formation. And what it does, it allows for the migration of the slower migrating and slower growing bone forming cells to resolve the osseous defect. The barrier membrane also stabilizes the blood clot very, very nicely. I'm going to show you an interesting case I did a while back. This case was referred to me to treat the vertical defect on the mesial of the distal abutment of this three-tooth bridge. If you look closely, you can see there's actually calculus on the root. What we did is we debrided the area very, very nicely. We used hand instrumentation as well as ultrasonic scalers. And then ultimately we treated this with a freeze-dried bone graft, barrier membrane, as well as biologics. You can see that the graft was filled with bone. That's the barrier membrane on top and the biologics being applied. This is a couple of month healing. You can see at this point the intraosseous defect is starting to regenerate. Soft tissue looks very nice at this point, no bleeding. Here's some post-operative radiographs. This is approximately a 7-month post-op showing regeneration in the mesial aspect of that distal abutment. Fast forward a few years. This is a follow-up x-rays in 2016, 2019. And also 2023. So what we did was we achieved some nice regeneration on the mesial aspect. We were able to retain the bridge, and we're getting some nice longevity associated with this regenerative procedure. What I try to avoid as a periodontist is if all you have is a hammer, everything looks like a nail. Meaning that being a periodontist, I think we have to look at things in a certain way in which we try to salvage teeth. Our knee jerk should be to try to salvage the tooth first. So what I want to do is I want to show you what I consider a very interesting case which depicts the necessity for guided tissue regeneration. Here's a lower right lateral incisor, which has a fairly significant buccal defect associated with it, which is obviously on the mesial and distal aspects of the tooth as well. Now, taking a look at this tooth, we have to make a decision. Are we going to try to salvage the tooth, or should we extract it and consider a dental implant or some other form of restoration? What I like to do is I like to look at a case and have like a thought process associated with it and to help me to make this decision. So what I do is I ask myself a couple of questions. The first question I ask myself, well, is this tooth salvageable? And my answer is, I'm not sure. I cannot necessarily look the patient in the eye and say, if I wave my magic wand, that this tooth will be salvaged. So I ask myself another question. Is endodontics necessary or even possible? Well, I looked at the radiograph. I can see the canal, meaning that endodontics is definitely possible. But when I pulp tested the tooth, it pulp tested positive. The tooth is vital. The next question becomes, is periodontal therapy a reasonable option? Well, we definitely know it's an option, but we cannot necessarily say with 100% degree of confidence that we can salvage this tooth, but it definitely is an option at this point. Then, if we go ahead and try to salvage this tooth, will this tooth be a suitable abutment after therapy? Also, the other question is extraction a viable option? Well, that's actually a very interesting question because if you look at the area carefully, there definitely is crowding associated with that. There is a little overlap between the lateral incisor as well as the cuspid. Interestingly, this patient did not have any other sites which were probing. So if we were to extract this tooth and we were to consider placing, let's say, a dental implant, we would also be involved in having to correct the horizontal deficiency to be able to place a dental implant with any degree of predictability. The other aspect of this is to place even an implant as small as a 2.9 is going to be kind of tricky because there really isn't an awful lot of space mesial distally to place this dental implant. So we also have to approach the patient with the concept that maybe the best restorative option might be some sort of bonded bridge at this point. Well, with that being said, we also have to consider what the prognosis is going to be like in 5 years. Is it from both a periodontal standpoint, endodontic standpoint, as well as prosthetic in certain cases. Truth be told, when we discussed it with the patient, the restorative doc and I, we ended up deciding that what we're going to do is we're going to consider periodontal therapy. At this point, that's the most reasonable option because tooth replacement is going to get kind of difficult. So we went ahead opened up the area, and we were very lucky to find that we actually had some calculus on this root, which makes many of us very happy. Why? Because now we have an etiology. So we debrided the area really thoroughly. We using both ultrasonics as well as hand instrumentation. And then we opted to treat this area with biologics as well as a freeze-dried bone graft. First, we apply EDTA, which is a chelating agent, and then we apply the biologics on top of that after rinsing the EDTA off very, very thoroughly. Here's our freeze-dried bone allograft being placed. This was mineralized freeze-dried bone at this point. A membrane on top of that, and then we place a couple of sutures. We always use the excess biologics to facilitate healing, and this is a 4-year post-op. Ultimately, the area healed up really, really nicely, and then we can take a look at some of the post-op radiographs. You can see the defect in 2017. This is a 2019 radiograph as well as 2021. So not only did we get resolution, but we're getting long-term follow-up and also what appears to be a healed osseous defect. Another case which I found very, very interesting is patient MS. He's about 67 years old at the time, ASA1. He's not on any medicines, but taking a look at this defect, you can see that tooth number 5 is no longer salvageable at this point. And the treatment plan here was probably the best option would be to take out tooth numbers 4 and 5, graft the area, perform a horizontal augmentation, GBR procedure, and then the final prosthesis will be a 3-unit implant-assisted fixed bridge. We obviously debrided that mesial aspect of that second bicuspid very, very thoroughly. We used a freeze-dried bone allograft. This is a mineralized freeze-dried bone. Placed a collagen membrane on top of the area. And this is the post-op about 4 months later. And interestingly, not only did we get very nice horizontal augmentation, but we also wound up rectifying that mesial defect on tooth number 4. And we were posed with a very interesting question, which we discussed with the patient. Obviously, we placed an implant in position number 5, but at this point, since tooth number 4 had a very good long-term prognosis, the thought process here was to have this patient remain with 3 individual teeth and not extract tooth number 4 and not fabricate the bridge. The area healed up very, very nicely. You can see this is the 2013 radiograph of that area after the implant had osseointegrated. This is the final prosthesis. This is a 2014 radiograph of the area, and you can see the tooth number 4 has some nice bone around it. And then if you fast forward a few years, here's your 2014 radiograph, 2018, 2020, and 2022, all depicting tooth number 4 having it's 10 years at this point, so we definitely have gotten some nice longevity out of tooth number 4, and it continues to go strongly. In order to have successful guided tissue regeneration, Dr. Hamlei Wang actually created what they call the PASS principle. PASS stands for primary wound closure, angiogenesis, stability of the graft, and space maintenance. And these 4 principles, okay, will ensure or help us to achieve successful guided tissue regeneration. Space maintenance is provided with our graft material. It's osteoconductivity, okay, and that's with one of the bones that we described earlier. Stability is achieved by your barrier membrane. That stabilizes the graft material as well as the blood clot. Angiogenesis will actually form a nice blood clot and aid in bone regeneration. Very, very critical. Primary wound closure is always something that we try to achieve in any form of guided tissue regeneration or even guided bone regeneration. Also, protecting the graft and stabilizing the graft as well. What I want to do is I want to show you how this PASS principle actually comes into play in treating this defect around the pier abutment in this 5-unit bridge. Looking at it from clinically, you can see some excessive probing depths on both the mesial and distal aspects of this tooth. And we went ahead and performed full thickness flap elevation. Here you can see the mesial and distal defects very, very easily. You can also see, if you look closely, there's calculus associated with these defects as well. We went ahead, used our chelating agent, EDTA, applied some biologics, the enamel matrix derivative in the mesial and distal aspects of that tooth and within the defects of that tooth. Then we used our mineralized freeze-dried bone allograft, placed a membrane on top of the area. The membrane stabilized the graft, and the primary closure also helped us out in terms of stabilizing and creating a better environment. We used the excess biologics to aid in our wound healing. And this is a 1-week post-op. This is about an 8-10 month post-op depicting healing of the periodontal pockets, some nice soft tissue healing and within a relatively short amount of time. But the best part about this is the post-op radiographs. Here's your 2015, this is your 2016 radiographs about 11 months later. You can see some nice regeneration on the mesial and distal aspects of the tooth. And these are some follow-up radiographs, and this is the 2017 radiograph, which also we wound up finding recurrent decay. So the 2 distal abutments wound up having to be replaced with new crowns, and then it was decided that we place dental implants in the edentulous areas and the lower bicuspid areas. Wound up placing 2 implants, but during the full thickness flap elevation, You rarely get to see osseous defects actually healed after a protracted period of time. But you can see some really, really nice bone regeneration, what appears to be viable, healthy bone on the mesial aspect of that lower molar. Ultimately, 2 dental implants were placed. Here's the 2 dental implants were osseointegrated. And here's the 2018 radiograph follow-up again with the mesial and distal intraosseous defects completely resolved. And here's one more follow-up x-ray in 2020. Now, looking back on the presentation, we do definitely have choices in guided tissue regeneration, no question about it. And we know that periodontal disease is the main cause of tooth loss. And I believe that we as periodontists should be looking to try to salvage some of these teeth. Guided tissue regeneration is a prudent approach to salvaging teeth, and it should be part of every periodontist's armamentarium. Freeze-dried bone allograft is often the treatment of choice in guided tissue regeneration. Both min and demineralized freeze-dried bone all work very, very nicely. With that being said, I want to thank you very much for your attention. And what I want to do is I want to move into the knowledge check. Question number 1. All of these are considered risk factors for periodontal disease except smoking, wearing an occlusal guard, stress, or diabetes. The answer is wearing an occlusal guard. Question number 2. When determining whether a tooth is salvageable, one must consider all of the following except A, if endodontic therapy is necessary, B, if guided tissue regeneration is necessary, C, if implant therapy is a viable option, or D, if the adjacent teeth have restorations. The answer is D, if the adjacent teeth have restorations. Question number 3. The function of the barrier membrane used in GTR is all of the following except A, preventing epithelial regeneration over the newly forming bone, B, allow for slower growing bone regeneration in the bony defect, C, stabilizing the blood clot, or D, act as a biologic barrier. The answer is A, preventing epithelial regeneration over the newly forming bone. Question number 4. The limitations and complications associated with autogenous bone grafting material include all the following except A, limited intraoral donor sources, B, 100% patient acceptance rate, C, high patient morbidity and costs, D, osteogenic and osteoinductive growth factors. The answer is B, 100% patient acceptance rate. Question number 5. Blood clot formation is key to successful GTR. Which growth factor is instrumental in angiogenesis? A, VEGF, vascular endothelial growth factor, B, BPH, C, HGF, and D, HDGF. The answer is A, vascular endothelial growth factor. This concludes this education module on the choices we have in guided tissue regeneration. This module was developed by LifeNet Health in collaboration with the American Academy of Periodontology, who endorsed this education module. I'm Dr. Bob Miller. Thank you for listening.